So it's with great honor for me to introduce the next speaker, Professor Vikram Patel, who works as a psychiatrist and a professor of global health at Harvard Medical School in Boston. And we are very glad that he is able to speak here within the team Translational Challenges in Psychiatry, because much of his work has centered on the translation of psychiatric science to the global mental health perspective, and also to psychiatry in developing countries, for instance, how to train health workers in developing countries to actually apply science and evidence-based psychiatry. So he published many of these studies in prestigious journals such as the Lancet, and he also greatly helped stimulating research funding in developing countries. So again, with great pleasure, I'd like to invite on the stage Professor Vikram Patel.
Thank you. Thank you very much. Good morning, and thank you very much. I followed a little bit of the Dutch, very little, especially the last slide. As I was talking to the speaker before me, it's so true that wisdom comes with experience, and experience comes with age. And I feel I'm in the same bracket as you. So I'm very glad that to be invited here today. Although I work at Harvard Medical School, I actually spend most of my time in India, where I work very closely with grassroots community-based organizations, especially one called Sangath. And much of my presentation today is influenced by 30 years of working first in Zimbabwe and then in India. Friends, I want to start by reminding us that mental health is something we all understand is very important, but actually it is something that is at the heart of society today. And I want to just start with a series of news stories from 2 or 3 countries that I know well. Let me start by showing you perhaps one of the most catastrophic examples of a mental health crisis that is unfolding in my newly adopted country. It is incredible to think that today, opioid overdose is the leading cause of death in young Americans between the ages of 18 and 45. Just think for a moment about this statistic. It is the #1 cause of death in young Americans, mostly white, working-class Americans. Not only is opioid dependence, of course, a mental health problem, but the very fact that led many of these individuals to receive opioids was also because of a mental health problem, poorly diagnosed and treated anxiety and depression in the context of unemployment and despair. In another country, which currently is, of course, curiously associated with the US, there is another kind of mental health problem that is also the leading cause of death in young men, at least in that country. In Russia and many Eastern European countries, alcohol abuse, not just through cirrhosis, but also through suicide and accidents, is now the #1 cause or risk factor for death in young East Europeans and Russians. Can you imagine? 2 mental health conditions are associated with mortality on an unprecedented level in 2 of the biggest countries of the world. Another big story in the US, but indeed globally, is youth suicides. Even though in the last decade, virtually every other non-communicable disease has shown a fall, including dementia that we heard about in the previous lecture, not with suicides, especially in young people. In my country, in India, suicide is the #1 cause of death in young Indians. Not just in India, in China, in Vietnam, in many parts of Asia, more young people will kill themselves than die due to any other cause. Farmers, there's an epidemic of farmers afflicting America's heartland. And indeed, In another part of the world, completely different economically, there's an epidemic of suicides killing farmers across India. In fact, in India, farmer suicide is now a political issue to the extent that elections are being fought and won purely on the subject of farmer suicide. It's very rare to find a health issue becoming a central point in an election campaign. But today, mental health is often an election issue. And of course, we just have to visit the big streets of any big city in the world, and you will see mental health problems played out right in front of your eyes on the streets. Now, we shouldn't be surprised, of course, that mental health problems are a daily issue in the lives of everyone in society. If you consider the fact that mental disorders are a rising cause of burden of disease. This slide comes from the Global Burden of Disease. I'm going to see if I can find the... If you can see this slide here, you will notice that in all the different countries of the world, classified according to their the burden, the level of socioeconomic development, these are the poorest countries of the world, and perhaps the Netherlands would belong here in the richest countries of the world. You will find that in the 25-year period from 1990 to 2015, there has been a rise in the burden of disease in all countries, but most dramatically in the poorest countries, where it's gone up from 2% to 4.3%, which is, of course, a doubling of the burden. And the main reason for that is because of aging. Not just aging in the extreme old age period of life, but aging in terms of children aging to becoming young people. And this is not surprising, because if you look at the distribution of that burden by age, and here on this axis you can see the ages from 0 to 95, and here you can see the burden of mainly mental disorders, but also we've added dementia, which in many parts of the world typically presents to mental health services, and self-harm, which for reasons that are hard to explain, the World Health Organization classifies as separate from mental health problems, as a cause of sickness. You will find there are 2 points in our life when we have an increased burden of mental health problems. The first point is in young adulthood, and the second point is in old age. But you can see here, of course, the big difference between young adulthood and old age is the fact that in old age, it's mainly dementia that is driving the burden of disease. And in both these ways, we are finding that there is a flood, a tide of the burden of these conditions, because populations in developing countries are moving from childhood into young adulthood, and in high-income countries, they're moving from adulthood into old age. Now, the good news is we all know, as a community of mental health professionals, that we have solutions. About 7 or 8 years ago, the World Health Organization, which very rarely produces treatment guidelines, very, very rarely. It's only done that 2 or 3 times before it did this. It produced clinical treatment guidelines for mental, neurological, and substance use disorders. Is there something unusual also in another way? It decided not to divide the brain up in the way we specialists do. We specialists like to divide the brain up into psychiatry and neurology and addictions, and even more so into child psychiatry and geriatric psychiatry. But of course, the truth is, in most parts of the world, there are none of us there. There are no child psychiatrists, there are no neurologists, there are no geriatric psychiatrists. So these divisions are meaningless. And for most services, most healthcare services, we need a combined set of guidelines to deal with all brain and mind conditions. And I congratulate the WHO for having done that. It's broken away from these medical specialisms and decided that really what we need is a united set of guidelines. And you can see it's not a complete list of conditions, but it's a very good start. And these conditions put together probably account for maybe 80 or 90% of the total burden of mental, neurological, and substance use disorders. So the point about these guidelines is we know what clinical interventions work, and importantly, in the last 10 or 15 years, we know how to deliver these treatments, even in places where there are very few specialists, very few mental health professionals. This is just a collection of some of the systematic reviews that have been published. These are systematic reviews. not individual studies. If I had to combine all the individual trials of the delivery of clinical interventions for mental disorders that have been combined in all these systematic reviews that cover psychosis, alcohol abuse disorders, depression, post-traumatic stress disorder, etc., including in rich countries, there are more than 150 randomized controlled trials. This makes it one of the largest bodies of evidence on how you deliver clinical interventions for any health condition, not just for mental health problems, but across the whole of medicine. And what I want to do is summarize some of the key messages that these trials have actually shown us. What they've shown us is that there are very important barriers on how we can take the incredible transformative treatments that we have outside our clinics so that we can reach people everywhere. And I really want to identify 3 important gaps that these particular innovations teach us about. But before I do that, some of you may be wondering, as I did 25 years ago when I began work in Zimbabwe, do the interventions that we develop and use in Amsterdam, London, and New York, do they travel to Harare, Kigali, and Mumbai? Aren't there differences between all these different peoples, cultural differences, that mean that the interventions will look completely different? I looked very closely at this, not only in my own work, but also in the work of many other people working in very different contexts. And reassuringly, I discovered that firstly, human suffering is the same everywhere. If you slap me, I will feel pain physically in the same way that I will feel pain emotionally. There is no difference fundamentally in the nature of emotional pain. Of course, culture matters, but the theoretical basis of understanding the nature of mental health problems and therefore the interventions are fundamentally the same everywhere. To me, this is an extremely important message that emerges from this very large body of cross-cultural research. But the second important finding is there are differences. Those differences are present in every society. And those differences are not cultural as much as social. Of course, culture is part of the larger social dimension, but what really matters is social class, how poor you are, or whether you're excluded or at the margins of whichever society you're in. And when you look at the adaptations that people have made for the delivery of care, you find that whether it's for African American people in the US, or gay and lesbian people in Europe, or for people living in poverty in India, those adaptations are often very similar. And what are those adaptations? So let me start with the human resource gap. I found out today from a new friend I've made here that there are about 4,000 psychiatrists or psychiatric trainees in this country. Now, this is the figure I received today on a message. And I believe there are 17 million people in the Netherlands. In other words, there are the same number of psychiatrists in this country as there are in my country, India, which has 100 times more people than the Netherlands does. Just think about that for a moment. And then I was told also that people in the Netherlands feel that we don't have enough psychiatrists. We need more. Okay, well, maybe you do. But I'll tell you what. You are not going to reach out to everyone, no matter how many of us we produce. I think what we're going to have to start doing is reimagining the way mental health care is delivered. And one way that people are reimagining it is through sharing some of our incredible knowledge and expertise with other people to do the sorts of things that you and I will not do. Particularly continuing care, provision of psychological and social interventions to people in their everyday lives. Through, for example, the revolution of community health workers. And I'll tell you it's a revolution. It's a revolution that is happening in the richest country of the world. In January this year, I was in New York City where I was part of a meeting hosted by the mayor of New York City and his wife, in which they are bringing the revolution of community health workers into the richest city of the world as part of a comprehensive mental health care system linking the mental health specialists of New York City with a whole army of community health workers who are based in a whole range of community agencies. Another interesting revolution is the idea that we should move away from packages of treatments like CBT for depression or dialectical behavior therapy for personality disorders and recognize that there are some very common psychological mechanisms. And the common elements approach allows us to actually begin to train everyone, including mental health professionals, in very specific techniques like behavioral activation or exposure, and learn how to apply these to people with symptoms rather than with specific diagnoses. This is another way, of course, of addressing the human resource gap, for example, that we have for specialists. The second is the access or the treatment gap. How do people access treatment? Well, we ask them to come and see us. From 9 to 1, I will be in this hospital. But unfortunately, for many people with chronic mental illness, to come from 9 to 1 when you're in the hospital is not possible for a variety of reasons. And so how innovators reach out to people is to go to them. To go to them when it's convenient to them. Now, you must be wondering, I'm not going to go out and see someone at 7 in the evening. Well, you don't have to if you actually connect with a community health worker who can extend your services out into the community, or that you use digital delivery so that you can deliver care remotely at a time when it's suitable to the patient. And it's interesting, we actually have been doing this for many decades through community mental health interventions, but other fields of medicine have gone far beyond us. Consider the area of TB. TB treatment only works if you take your treatment for the 6 to 9 months that you're supposed to take it. Patients don't take their treatments just as they don't take our treatments, because they have social problems that come in the way of taking their treatments. So what did the TB guys do? They invented directly observed TB therapy, DOTS. Now, I'm sure some of you have heard of it, but those of you who haven't, I should tell you what DOTS is. It's not some sophisticated digital treatment. It's a guy coming to your house on a bicycle every day and giving you the pill and watching you take it. It's directly observed treatment. That's what it is. Not very sophisticated, but it works. And then you've got the third kind of gap, and this is a slightly complicated one and maybe challenging for us, the credibility gap. In my work, and the work of many other people working in poorer communities, the one thing people don't like is diagnostic labels. And what's really interesting is that neuroscientists don't like diagnostic labels either. It turns out that both neuroscientists who come from the hard science background and anthropologists and community-based workers who come from the opposite background both agree on one thing, that our classification system is often a hindrance to acceptance of our models of care. I think we have to start thinking about that in a practical way. How do we actually translate this into the real world, prioritizing patient needs, the use of step care approaches, and I'll talk about that in a moment. Making sure that interventions are not contingent on diagnoses. We don't need to impose a diagnostic label in order to deliver a psychological, a drug or social intervention. Not pretending that people don't have resources of their own. Not everyone does, but the majority of people have families or rather community resources that we can mobilize. People are not passive recipients of a medical intervention. Most mental health problems coexist with social determinants, and we need to engage with those social determinants. So this is a very large body of evidence, and it's really best understood through the delivery model of collaborative care, in which we as psychiatrists play very important roles, as you can see here, but a key individual in this model of care is a kind of a community-based agent who actually connects the primary care provider, the specialist care, and the patient. Now, I know I'm talking to a conference of psychiatrists, and I am a psychiatrist. And I know that very often when we talk about these models of care, many of us feel threatened, and we believe that we are being sidelined. In fact, I think it is exactly the opposite. These models of care cannot work without our full and total engagement and collaboration. Because without us playing all the roles that I describe on this slide, models of care that seek to extend all our expertise out in the populations will not succeed. We are the ones who are innovating these designs. Every single example I've given you has been led by a mental health specialist. We enable this to happen by training. We help ensure quality by supervising. We champion the idea that psychiatric care can transform lives, and we have to make sure it gets out into the population. We evaluate what's going on. And of course, we also recognize that there are individuals who need the kind of complex, long training and experience that we have. And so we provide specialist care for those who need it. This sort of evidence base is redefining mental health care by redefining what is a mental health care intervention, how it's delivered, where it's delivered, and who delivers it. And you see this now influencing high-profile medical journals. 11 years ago, the Lancet produced the first series on what was then called global mental health. The World Bank has just a couple of years produced a volume that is defining all the interventions that are ready for governments to start paying for. In my own work, I do a lot of work with frontline workers. There are clinical interventions that are now being translated into practical clinical guidelines, including in digital versions. And the World Health Organization, 2 years ago, every single country in the world, they rarely agree on anything, but in fact, they all agreed on one thing, that in fact, we need a better global response on mental health care, and this is the Mental Health Care Action Plan that every single country in the world agreed to, including the US, which is uncommon because they usually don't sign on to many of these UN treaties. Now let's look at the reality. So we have all this science, we have all this knowledge. What is the truth on the ground? The truth on the ground is very grim. Let's start by asking the question, in spite of all the knowledge of all the wonderful interventions we have, how many people actually get these interventions in the way that can actually be reflective of the protocols? Now here I want to show you the figures just for depression, anxiety, and substance use disorder. These are collected from a number of different sources. For the lowest countries in the world, as you can see, about 95% of people with these conditions did not receive minimally effective treatment. 95%. I can't even imagine any other health condition for which there is such a huge lack of huge unmet need for care. But let's look at a country like the Netherlands, a high-income country. What is astonishing is that even though there are 100 times more resources, maybe 1,000 times more resources per capita, even then, the treatment gaps are 80%. It's quite clear that simply having more money thrown at the problem and more specialists thrown at the problem isn't going to be the only. We do need more, but that alone is not a solution. And when you do seek care, these are recent images of not prisons, not torture chambers, they're actually mental hospitals. These are mental hospitals from different parts of the world, Eastern Europe, India, Indonesia, and Chad. This is the kind of care that continues to be perpetrated under the name of mental health care, something my colleague Arthur Kleinman refers to as a failure of humanity. Let's not forget that there are other kinds of ways in which we torture people with mental illness. In my other country, the US, this is an astonishing statistic that many of you will be familiar with, but I just read a report last week from the Department of Justice in the US that reported that more than 50% of all women in America's prisons have a diagnosed mental disorder. That is astonishing. More than half of all imprisoned American women are mentally ill. And of course, these are hellish places to be. This is a report from the Guardian newspaper just last week on the mental health crisis overwhelming America's prisons. What they've done is they've closed the hospitals, but they've done nothing else in the community. And so effectively, people have moved, and I'm sure I've seen this in London when I trained in the late 1980s. People just moved from one kind of prison to another kind of prison. Unfortunately, these prisons are horrific places. This is a story that came out last year, actually, in the New Yorker magazine, and it describes how appalling the torturous conditions are for people with serious mental illness in those prisons. It's very similar to what you see in a developing country. It's really no different, except that it's a prison rather than a hospital. And then, of course, you also have other kinds of consequences of this massive unmet need for care. This is a report from the UN, which reports on the amount of lost time at work, and as a consequence, the UN has produced this report estimating that $16 trillion will be lost from the GDP of the world over the coming years because of untreated anxiety and depression. Now, it's not surprising that we have so much unmet need of care. Although I did say that rich countries spend a lot more than poor countries, this is not surprising because, after all, it is a rich country. It spends more on everything than a poor country does. But the question is, does it spend how much it should if you consider the proportion of the burden of health problems posed by mental and substance use disorders? And so here we've divided the world up into the poorest and the richest. Let's just look at India here, and we look at the Netherlands here. And you'll see that in both groups of countries, there's a similar picture. Even though the Netherlands will spend a lot more than India will, that's the bar on the extreme left, is the percentage of total health spending on mental health. It's almost negligible in India, much higher than in a rich country. But you can see that in both countries, these other bars are the burden posed by mental disorders in those countries. You will see that in both countries they share one thing in common, which is that the government spends much less than the burden that those disorders pose on society. Rich countries also spend less on mental health when it comes to donations, to aid. For the poorest countries in the world, mainly in sub-Saharan Africa, the health budget is almost entirely funded through development assistance. For example, DFID in the UK, and there's also a similar agency in most rich countries. This slide shows you how that aid is used according to different diseases. And on the left, you can see here, this is the development assistance in dollars per DALI, DALI being a metric of the burden of disease for HIV/AIDS, maternal health, malaria, and TB. You can see it's pretty high, especially for HIV/AIDS. Now, some of you may be thinking, I'm going to press a button, and we will see the bars for these two. Actually, I don't need to, because there is no bar for these two. You can't see it because actually it doesn't exist. This gives you a sense that it isn't just that countries are spending less on their own mental health care budgets, but they're also giving very little to the poorest countries in the world for their mental health care. So I'm going to finish off now by looking ahead. We've got this incredible science of the clinical interventions, social, psychological, and drug, that can transform people's lives, and we're doing very badly, worse than any other branch of medicine, in actually getting our knowledge out into affecting the population. And we have to start thinking as a psychiatric community in a completely different way. First of all, we have to stop whinging and complaining that we are being marginalized. Because actually, as long as we continue to have this fortress mentality that we are under siege, that we are under threat, people will not work with us. We have to start opening our minds out. We have to engage communities, and especially those who have been affected by mental disorders. We have to engage actively our political leaders. And let me tell you, times are changing, as I'll show you in a moment. They are interested more than ever before in our field. We have to engage young people. This is such an important demographic because this is the group which is most interested in mental health, but also it's the group in which most mental disorders begin. And we have to start thinking outside our discipline of purely clinical science. We have to work with neurosciences, with public health sciences, and with social sciences around these two important challenges facing our field of prevention and implementation. I mentioned that the time is right. Why do I say that? Well, for the first time in history, mental health is explicitly included in a high-level global development policy. The Sustainable Development Goals establish a development policy for the whole world, for all nations. And mental health is represented both in terms of promotion and prevention as well as treatment, as one of the targets for the Sustainable Development Goals. The World Bank, I'm sorry if you can't read that very clearly, last year the president of the World Bank hosted a high-level summit along with Dr. Margaret Chan, the director of the World Health Organization, where they declared together that mental health was a global development priority. The only time they've ever done this before was with HIV/AIDS. And we've seen the transformation that has happened with HIV/AIDS. By making it a global development priority, the World Bank now insists that every loan and grant it gives to a country for health sector reform must include a mental health item. It must explain how it will use money for mental health. Earlier this year, the World Health Organization Director General appointed an independent high-level commission on NCDs to report to the UN Secretary General in September. Mental health is included for the first time in history alongside the NCDs. And as I mentioned to you, rich cities like New York City are investing, in this case, the New York City government is investing $1 billion, not 1 million, but $1 billion to back a comprehensive citywide program for mental health care that follows all the principles that I shared with you earlier. And so I want to end by telling you about a very important event that will happen in the coming months in terms of the science of going forward for our field. About 25 years ago, this particular report was produced by my colleagues in Harvard Medical School. In the fall of this year, we will produce another major report as part of a new commission for the Lancet Medical Journal on global mental health and sustainable development. I want to leave you with some principles that are lying at the heart of this commission and which I've also tried to share with you today. Our vision, first of all, is to move beyond this idea of just improving access to care, but actually going very ambitiously to saying that beyond access, we have to focus on both prevention and the quality of care so that ultimately we can reduce the actual burden of mental disorders in the same kind of way that cardiologists can say, we reduce the burden of heart disease. We have to go very positively, thinking ahead. It's not just about access of care, it's about actually reducing the burden of disease. And to do that, we have to first recognize that global mental health affects all countries. This is not about developing countries, because as far as mental health is concerned, no country is truly developed, as we have seen, including, I think, the Netherlands. Secondly, that we have to go beyond binary diagnostic models of mental illness. It's not like you have depression or not. It's a staged model of care. There's a lot of people in this country, for example, like Jim Van Os, who have described this. We need to be moving towards hybrid, more complex models of staging, which lend themselves to a step care system of understanding how you deliver care for mental health problems that includes self-care, prevention, and promotion. We need to have a life course perspective. Every individual has a unique story that is a result of a combination of determinants that act at different points in your life course. It is not the same as a physical health problem. And finally, that mental health must be conceived of as a fundamental human right, one that affects all populations, but especially as a fundamental right for those who are vulnerable, such as those affected by conflict, child neglect, and extreme poverty. And of course, we must never forget the rights of people with serious mental disorders always. This is a moral imperative for mental health and sustainable development. I leave this word, leave no one behind, because that is what the SDGs use. The Sustainable Development Goals' central mantra is leave no one behind. And if we have to make sure we leave no one with mental health problems behind, we have to implement a much more comprehensive approach to mental health care for both treatment and prevention. And this is my last slide, and I just wanted to just share with you finally, just last weekend, in fact, on Thursday and over 3 days, a major event was hosted at Harvard University where we've launched this new initiative that really does seek to, in fact, put into practice some of these ideas, especially the idea that the clinical sciences of psychiatry and psychology must work very closely with the neurosciences, public health sciences, and the social sciences if we are really ever going to achieve a solution for this very complex problem of mental health. Well, thank you very much for your attention.